Next we have Dr. Radhika Natarajan from Shankar Nethralaya. She's the Deputy Director of Cornea Services at Shankar Nethralaya, and she'll be talking to us about aphakia management in a grafted eye.
Good morning, I'm Radhika from Shankar Nethralaya. Well, this is definitely the era of layer transplants, elegant endothelial keratoplasties and anterior lamellar keratoplasties. But when you see a corneal opacity which is similar to the one seen in picture A over there, one definitely needs to do a penetrating keratoplasty. In the panel below, you see a picture where you have very poor intraocular lens support. So in these cases, a capsule bag fixation of the intraocular lens may not be possible. So when we encounter a combination of these two, a severe corneal opacity which has affected all layers of the cornea with poor capsular support for the intraocular lens, then what do we do? So the common situations that we encounter both together would be a very severe bullous keratopathy which has affected all the layers of the cornea and the initial surgery has weakened the capsular support as well, or B, a situation where injury or trauma has compromised all the layers of the cornea as well as the capsular support. So these are situations where one is forced to do a penetrating keratoplasty with a suture fixation of the intraocular lens after the cataract is removed. The Yamani technique of intrascleral haptic fixation has been discussed widely in many contexts, but it has not been very well reviewed in the context of penetrating keratoplasty. PKP, when it has to be combined with a fixated IOL, has been combined with the traditional 4-point SF-IOL technique, which is the gold standard for these kind of surgeries. But even though in this time-tested procedure, we have several issues like suture breaks, IOL tilting, and other problems. So we proceeded to see if the novel technique of combining the Yamani's intrascleral haptic fixation works for a PKP as well, and we tried to evaluate the outcomes that we got. So my talk will be specifically on this. The 3 patients who formed our learning curve all had severe corneal decompensation with scarring, which was not amenable to layer or endothelial keratoplasty, and they also had poor support for the intraocular lens, as evidenced by their subluxated lens and their displaced haptics, etc. So the technique itself is very simple, the surgical technique. A mark is made even before the surgery is started, 2 mm behind the limbus, as you can see in the first panel. So this denotes the spot where the needle will enter. And another mark is made 3 mm away from the first mark, which denotes the track of the needle or the track where the haptic will lie after the surgery. After making these two marks are better made one diametrically away from the other, 2 sets, and these are better made away from the area where the ciliary vessels will enter. So the 3 and 9 o'clock positions are best avoided. So once these 2 marks are made, a similar set of marks is made 180 degrees away, and the corneal button is refined out in a regular fashion. A 26 or a 27 gauge needle, which is bent, is used to enter the eye through the first mark, and the needle traverses up to the second mark intrasclerally and then enters the eye as with any other traditional Yamane surgery. The tip of the 3-piece haptic is then loaded on or guided into the needle. This is best practice outside the surgery so that one does not encounter threading problems during the surgery. And this haptic is externalized, and a similar procedure is followed with the trailing haptic. Now we know that the trailing haptic insertion is the most difficult in a traditional Yamane technique, but over here in a PKP, because the open sky confers axis, the trailing haptic is as easy to externalize as the leading haptic. So once the haptics are out, a battery cautery is used to create the flange with a non-touch technique. The flange is created by the cautery coming close to the haptic, and then the haptics are pushed back into the scleral tunnel, and the donor cornea is capped on, and the penetrating keratoplasty is completed in a regular fashion. So we had this learning curve of 3 patients, And in patient number 2, in the immediate postoperative period, we found that the haptic was lying subconjunctivally. So we took the patient up again and we trimmed the haptic, we recreated the flange, and we reinserted it back into the scleral tunnel. And the second patient, we found the same problem happening at glass appointment at 6 weeks. So 6 weeks is a long time for us to push the haptic back because the tunnel might have fibrosed and we may be introducing infection. So what we did was to do a small patch graft after opening the conjunctiva to cover the haptic. Intraoperatively, both the patients did all right. It was in the postoperative period, one early and one late, that we found these haptics outside the eye. So we were wondering why this happened. We figured out that the 3 millimeter long tunnel that we had created intrasclerally probably becomes much smaller when there is a scleral collapse after the corneal cap is opened. So in the third patient, we elongated the tunnel to about 4 to 5 millimeter, even 4.5 millimeter, and it threaded beautifully inside. It never prolapsed in the postoperative period. So this is the patient for whom the patch graft had to be done to conceal the haptic. And after the series of 3, we've done 3 other patients with longer scleral tunnels, and intra and postoperative periods have been uneventful. So when you combine PK with the Yamane intrascleral haptic fixation intraocular lens technique, it reduces the open sky time because there are no sutures to contend with. If the view is slightly clear, if the cornea would allow it, one can even do a partial thickness trephination and complete it in a semblance of a closed chamber. One need not even decap the cornea entirely to do the procedure. It's got a very less steep learning curve as compared to scleral fixated IOL. But the one advantage that we saw was, in most of these cases, it's either trauma or a stormy pseudophakic bullous keratopathy that leads us to this procedure itself. The same would have also compromised the iris in many parts. So when the iris is deficient, the intraocular lens, it swings like a hammock when you have scleral fixated sutures, and it can touch the cornea. Here, the fixation in the sclera causes very less pseudophacodonesis, and when iris is deficient or absent in these stormy situations, the corneal touch by the intraocular lens is also minimized because there is no hammock or swinging effect that happens in this type of scleral fixation. And there are certain disadvantages. The ones that I prominently would mention are the gauging of the intrascleral tunnel. The intrascleral tunnel, if you make it a little longer, then you can circumvent this problem because PK will cause a collapse of the sclera, and therefore haptic extrusion is a definite possibility. When I spoke about this to the master himself, Dr. Shin Yamane, what he suggested was the trimming of the haptic that we used as a rescue measure for one patient can be done as an elective measure itself. When you're using the haptic to thread, it can be trimmed first before the flange is created, so that even if your scleral tunnel is little bit on the shorter side, you prevent it from prolapsing into the subconjunctival space in the postoperative period. So you either make a longer tunnel or you trim the haptic electively itself, before you try to insert it. So this is my Yamane moment. Of course, different techniques work very well with different hands, but this technique of combining the Yamane IOL with the penetrating keratoplasty surgery could be a value addition in the skill set of the keratoplasty surgeon. Thank you so much.